This topic tonight, I apologize a little bit in advance. It's a little technical, and I'm going to try to go through it in a way that we can all get something out of it, but some of the terms that we're going to use this evening may be terms that some of you are unfamiliar with. So in the original flyer, we had titled this lecture Stem Cell Therapy in MS, but it's really a little bit bigger than that. So we're going to talk about different types of stem cells, but we're also going to talk about some other topics in that same category. So there are really four subjects that we're going to address this evening. We're going to talk about autologous hematopoietic stem cell transplantation. I'm going to go over some of these individual terms and talk about what is a hematopoietic stem cell, what does autologous mean. We're going to talk about mesenchymal stem cell transplantation. We're going to talk about pharmacologic manipulation of endogenous stem cells. Basically, how do we take advantage of natural repair mechanisms? We're going to talk a little bit about something called OPCs, Oligodendrocyte progenitor cells. Oligodendrocytes, what do those do in the body? They make myelin, so that's an important thing in multiple sclerosis. A lot of what we're going to talk about this evening was summarized at a meeting in 2015 and then put together in a great paper. If you go online and you look up the journal called Brain, the title of the paper is actually Cell-Based Therapies in Multiple Sclerosis. And so they put everything together that all of these experts had to say at this meeting in 2015 into this paper. So autologous hematopoietic stem cell transplantation, what the heck is that? So the idea behind this is that we're giving a person a new immune system. Multiple sclerosis is an autoimmune disease. It is your immune system picking on something that it shouldn't be picking on. If the immune system is what's driving the problem, what if we just gave you a new immune system and started over again? It's like rebooting your immune system, if you will, with a fresh immune system. We have to wipe out the existing immune system before we get there, and we'll talk about all of these individual steps and some of the challenges and questions that we have. Autologous, that means that the transplant comes from you. It's your own tissue. You are the donor. That's in contrast to allogeneic. So if a person has a bone marrow transplant for cancer, for leukemia, usually that's an allogeneic stem cell transplant. That comes from their brother, their sister, an unrelated donor who happens to match that person's tissue type pretty closely. So everything that we're looking at in MS in hematopoietic stem cells is autologous. It comes from your own body. So what do we mean when we say hematopoietic stem cell? We mean an immature cell from your bone marrow that has the potential to grow up to be red blood cells, platelets, or any of the cells in the immune system. So white blood cells, macrophages, any of those types of cells. So there are basically three steps when we talk about an autologous hematopoietic stem cell transplantation. The first step is something called mobilization. We've got to get those stem cells from your bone marrow out into the bloodstream where they can be collected. You could do it through a bone marrow biopsy, but it would take a lot of cells from the bone marrow, and bone marrow biopsies are not the most pleasant thing in the world to have done. So the way that we get those cells out of your bone marrow is by using natural sort of compounds, something called granulocyte colony stimulating factor, that basically is given as a subcutaneous injection, and it tells those cells, it kicks them out of the bone marrow and puts them into the bloodstream. Now that those cells are in the bloodstream, we can actually draw them from the blood with something called pheresis, and we're going to freeze them and save them. Now we go to the next step called conditioning. So we said we need to give you a new immune system. Well, to give you a new one, we've got to get rid of the old one. And that's some type of chemotherapy regimen called conditioning. This is probably where most of the risk is involved with an autologous hematopoietic stem cell transplant. We've got to give high doses of chemotherapy to wipe out the existing immune system. One of the areas of discussion in this research is how much chemotherapy do we give? Most of these chemotherapeutic regimens are divided into what we call myeloablative, meaning we're giving high dose chemotherapy and really trying to wipe everything out, or non-myeloablative. So this is a little bit lower dose of chemotherapy, not quite as aggressive, probably a lower side effect risk. So if you give more chemotherapy, you're going to wipe out more of the existing immune system, and you have a chance to have better effectiveness. You also have a chance to have more side effects. So everyone's trying to find just that right balance of how much chemotherapy we should give to get the most benefit with the fewest side effects. The third step is recovery and reconstitution. So after the chemotherapy is given and your existing bone marrow is shut down, we can't let you go that way. You would die without an immune system, so we need to reboot that immune system. We're going to give you those cells back that were frozen and saved and let you regenerate a new immune system. Usually these cells start regenerating at somewhere between 3 and 4 weeks. That period of time where those cells are regenerating, that person literally has no immune system. So there's risk of them picking up infections, and a lot of the serious side effects that can be seen with this procedure are in that period of time. If someone has a serious side effect from autologous stem cell transplantation, it's usually going to be in the first year. Really, it's usually in the first few months of having had it done. So how does it really work? So it seems intuitive that you would think, okay, I'm giving you a new immune system, one that doesn't have the knowledge of how, so it's really the new immune system that's the treatment. There are some researchers, and they are in the minority, that says, you know what? The actual treatment of this procedure may be the chemotherapy. Maybe we're giving such aggressive chemotherapy and it has such a strong anti-inflammatory effect that really is the long-term treatment. We know from trials with drugs like Cytoxan or cyclophosphamide that you can give high doses of cyclophosphamide to someone with active MS, essentially drastically quiet down their immune system, and they may get benefit for years and years to come. So some people would argue that the treatment is the chemotherapy. More people believe that it really is the new immune system that is the treatment, that is the long-term benefit, is rebooting your immune system. So what have we learned so far about autologous hematopoietic stem cell transplantation? It can be very effective, but we need to think about who we're doing this in. It's most effective if you pick the right person. There's the term out there that we may have mentioned before called NEDA, N-E-D-A, no evidence of disease activity. That's what we're really shooting for with MS treatment these days. We would like you to have no relapse, no progression of disability, and no new lesions on MRI. That's NEDA, no evidence of disease activity. So there's been some recent studies that have put together all of the trials of this stem cell transplantation and have looked at people at 2 years and 5 years out. And what we saw was that at 2 years, 78 to 83%, so a good majority of people had no evidence of disease activity. That number went down to 67% at 5 years, but still pretty significant. So how does that compare with a very effective disease-modifying therapy, a drug like Tysabri? So there was a recent study that looked at people 7 years out on Tysabri, and what they saw is that about 41% of people had no evidence of disease activity. So one of the challenges as we go forward and as autologous stem cell transplantation maybe becomes more mainstream, more available to individuals with MS, how do we pick? Who's better for Tysabri or Lemtrada or Ocrelizumab or Gilenya or any of the therapies we have now? Who's a better candidate for that versus this sort of treatment? And it's really going to come down to the risk-benefit ratio, I think, in selecting the right individual. The cost in the United States of autologous stem cell transplantation is about $120,000. It is still considered experimental, and so it is a challenge to get an insurance company to pay for this. We're still very limited in the number of centers who have a lot of experience. You know, Dr. Burt up in Northwestern is probably one of the leading researchers, but there are far more people who are interested in this procedure than there are slots to be made available for those individuals. So we talked about picking the right person. So who is the right person? And I wouldn't say this is set in stone, but the trends are pretty strong. So what research has suggested is that really the ideal individual to consider for this procedure would be someone with aggressive relapsing remitting MS, frequent relapses, evidence of inflammation on their MRI or enhancing lesions. Ideally age less than 50. It seems to be a less risky procedure in people under age 50, and their MS diagnosed within the past 5 years. So what about the safety of the procedure? It's gotten better. Some of the early trials of hematopoietic stem cell transplantation saw death rates in the 5% range. That's gotten much better. Some of the recent trials have actually had 0 mortality. That's not to say there are not other side effects, but at least the safety seems to be getting better as we learn more about this. There is an increased risk of side effect and death as the patient's age goes up and as their level of disability goes up. So what do people do if they're interested in having this done, but they can't get into one of the research settings like at Northwestern? Some people are going abroad, and we've had several individuals that we take care of who have gone out of the country to have this procedure done. Some people are looking at having the procedure done in Mexico or in Russia, and we've had some of both. So what are some of the advantages of going abroad? It's cheaper. You're still going to pay out of pocket, but typically abroad you're going to be looking at about $50,000. They are going to probably make this procedure available to a wider range of patients. If you're participating in a study in the US or Canada, they're going to have fairly narrow windows of the age and the type of disability, the relapsing versus progressive MS. Some of the centers abroad are not that discriminating. That's also a potential disadvantage. So the disadvantage, even though it's less than half the cost of what we see here in the United States, $50,000 is still a lot of money. It's an expensive procedure. Those loose patient selection criteria are both a blessing and a curse. It's available to more people, but when you start doing the procedure maybe in progressive forms of MS or in people who are older or have a lot of other health problems, you're probably going to see a lot more safety concerns in these facilities. The follow-up can be very iffy at some of these facilities. So imagine you've saved up $50,000 and you go to Moscow and you have this procedure done. What's the likelihood that you're going to go back to Moscow every 3 months for follow-up visits? Probably about 0. Our patients who have been to Mexico, a few of them have gone back for follow-ups, but the majority not going back for follow-ups there. So shifting on, that's that second type of stem cell procedure, mesenchymal stem cells, or MSCs. Mesenchymal stem cells have the potential to become a lot of other types of cells. What they can't become are hematopoietic cells, so these are very distinct, different types of cells. So a mesenchymal stem cell can't become a red blood cell, or it can't become a cell of the immune system. They also can't become cells in the brain and spinal cord, like neurons and oligodendrocytes. They're found in a lot of different places. They're pretty easy to find. They're in adipose tissue, in fat. They're in muscle. They're in umbilical cord blood. They're in the bone marrow. So it's a fairly widespread type of cell. One thing that we're learning is that they're not all the same, though. So a mesenchymal stem cell that you get from fat, which would be pretty easy, me included, I have some extra mesenchymal stem cells, lying around that someone could harvest. Those are probably different from cells from the bone marrow. They may differentiate into cells that help repair damage in the brain and spinal cord. And so that's the real hope and the goal of mesenchymal stem cell transplantation, is that we're going to see neural repair and reversal of disability. The interesting thing about them is they seem to go where they need to go. If you put these cells into the bloodstream, or if you put them into the spinal fluid, they seem to go to areas of damage. It's almost like a homing signal, if you will, calling them in. The cells from the mesenchymal stem cells from the bone marrow, interestingly, if you get them into the central nervous system, research has shown that those cells may survive for decades in the central nervous system, whereas the mesenchymal stem cells from fat, not so much. So it raises questions about, is this a one-time procedure if it's maybe cells from the bone marrow, or is this a type of procedure that you're going to do repeatedly over years because the cells aren't going to last very long? And these are all issues that are still being sorted out. So the benefit, the reversal of disability and the repair, interestingly, if these cells don't become oligodendrocytes and they don't become neurons, how are they repairing the damage? It's probably not the cells themselves. It's probably something that they're producing, a chemical that they're producing at the site of injury that leads to the repair. So if that's the case, can we just identify whatever that compound is that they're producing and skip the whole cell transplant? So a lot of researchers are working on this, trying to identify what it is that these mesenchymal stem cells are making. One of the compounds that's been looked at is hepatocyte growth factor. It looks like that may lead to some of the repair in the central nervous system. So that would let us, again, just move things along that much more quickly. So these things can be given intravenously. Again, if you put them into the bloodstream, they seem to go where they need to go. They can be put into the spinal fluid, and maybe that's a little more effective. Maybe you're putting them closer to the source of injury. And then probably the least appealing way would be to put them into the tissue itself, the tissue being the brain or spinal cord. We're a little nervous about putting needles into the brain or spinal cord, but there has been some research looking at that, probably more so in spinal cord injury. And we've done some of that research here at Shepherd Center looking at that. And we're going to see if we can hold questions towards the end if we can. So what do these mesenchymal stem cells potentially do? Well, they potentially remyelinate, they potentially reduce scar tissue. Gliotic scar tissue in the brain and spinal cord in multiple sclerosis is one of the inhibitors of remyelination. So if you can take that scar tissue away, you have the potential for better repair. They may promote new blood vessel formation around those areas of scar tissue, decrease inflammation, and may protect those cells in the brain and spinal cord from further damage. So some of the unresolved questions, this would seem to be pretty simple. Just get a bunch of these mesenchymal stem cells and just put them into the bloodstream or into the spinal fluid. Some of the unresolved questions is, what's the dose? How many of these cells do you need to actually get repair? How often should you be doing this? Is it a one-time deal or a repetitive procedure? What type of mesenchymal stem cell should we be using? The ones from the bone marrow or the ones from fat? Or how about umbilical cord blood? Is that going to be a source for them? And then the cells themselves can actually be treated. You can take those cells directly from whatever tissue you're using and put them in an unadulterated fashion, or you can select for certain types of mesenchymal stem cells, maybe cells that are more likely to become certain tissue lines. So there can be processing of those cells that goes on afterwards. It's complicated. And that sort of complicated nature of mesenchymal stem cells, it should give you pause when you start thinking about I'm going to come back to that in a second. It should give you some pause when you think about where you have this procedure done. So some of the study results to date, some of the studies have shown that it seems to be a very safe procedure. We've not seen a lot of side effects with this, whether the cells were given into the bloodstream, into the spinal fluid, or sometimes into the tissue itself. In terms of what we're seeing for results, it's been a mixed bag, but we are seeing results in terms of reversing disability. So I think mesenchymal stem cells hopefully is going to be something we hear a lot more about going forwards. Just like people are anxious to do the autologous stem cell transplant, and maybe they can't get it done here in the States, so they go abroad, people are looking at mesenchymal stem cells being done abroad. And to me, this is a little more problematic than the hematopoietic stem cell transplants. It seems to be a lot less regulated, and there are a lot of these stem cell for-profit clinics that are popping up all over the place. If you're on Facebook, I know I get things on Facebook from 2 of them here in the United States, at least on a monthly basis, advertising, you bring your $20,000 and they will do this procedure for you. There is so little information out there on where the cells are coming from that they're using, how are they processing them, what are their safety procedures and their sort of laboratory quality control measures that they're using. Again, this is, we sometimes say something's not rocket science. This kind of is rocket science. And for some one of these clinics to just pop up overnight and start throwing these cells into human beings is a little bit scary. So what are some of the warning signs that maybe that you want to kind of slow things down a little bit? If they're advertising on social media, that should be a little warning sign. If they treat everything and everybody, if they're treating ALS, Parkinson's disease, Alzheimer's, autism, multiple sclerosis, ingrown toenails, that's a warning sign. If they don't publish any research, if everything on their website is about testimonials and anecdotal reports, that's a concern for them. What we've seen here in the past few months is because I think they've heard that criticism that they're not doing research. So what some of these for-profit clinics are doing now is offering research. And when you really call them on it, though, it's not research. What they're doing is they're still taking your $20,000 and they're giving you some surveys to do after you have the procedure. And so they're collecting some data. They've not published anything yet, but they're sort of making their marketing efforts look like a research effort. So the next one they're going to shift to is I think also a really promising and sort of interesting area, and that's the idea of not transplanting cells into the body, but trying to take advantage of cells that are already there that can repair damage and just make them do a better job of it. So this is pharmacologic manipulation of natural repair mechanisms, or kind of the search for molecules that is going to enhance this repair. So when you think about how research is normally done and how we develop treatments for a number of different health conditions, MS included, this is what it usually looks like. Usually someone has an idea or a concept. That's going to usually go to animal studies. That's going to, if it looks good there, it's going to go on to human safety and dosing trials. These are phase 1 clinical trials. So this is research where you're going to get a bunch of young, healthy volunteers. They don't have the health condition you're looking at. You're just trying to get a sense of what this treatment looks like in a human being and get a sense of what the dosing should look like. And then these individuals are usually paid to put up with the risk and the hassle of doing this. Once that passes, then you're going to actually start looking at the health condition that you're interested in and trying to get the dose right. That's the phase 2 human safety and dosing trials. The phase 2, they're going to start looking at some effectiveness also along with the dosing. Then you get into the big studies, and this is where clinical research usually starts getting the attention of the press and the patient populations. These are phase 3 human comparative trials. So you're going to compare your treatment either to another active drug that you know works, or you're going to compare it to placebo. Once all of that is done, and it usually takes at least 2 of those big phase 3 studies, and usually these are done at multiple sites across the globe. If all of that looks good, then that goes to the FDA for approval, and that has a certain sort of time frame that it takes for them to go through their approval process. The average length of time from concept to FDA approval is 14 years. The failure rate is about 92%. So it's a long, drawn-out, expensive process. What if we could move things along a lot more quickly? And this is some research that just came about within the past 2 years. And this is a way of trying to identify magic bullets that might repair damage in the central nervous system. And the idea is to not take brand new molecules that have never been looked at. It's to take everyday, common, maybe over-the-counter drugs and see if just by some random chance these things would actually repair damage. And the concept is to use something called a micropillar array. So they actually take sort of fake axons, if you will, or micropillars, and in that sort of test tube, they're going to put oligodendrocyte progenitor cells, the immature cells that have the potential to grow up to be myelin-producing cells. But a lot of times those OPCs, those oligodendrocyte progenitor cells, if you don't give them a signal, something to kickstart them, they'll just sit there and they won't make myelin. So what they're doing is taking molecules that are already FDA approved, already have a known safety profile, and they're saying, Will this molecule kickstart those OPCs into making myelin? And you can run 1,000 of these micropillar arrays, and again, you're just no rational thought behind why this would repair. You're just putting these molecules in and see if it's going to repair damage. This cuts years out of the process, of several steps out and years out of that process to identify molecules. So far, we've got at least 4 that have been identified as being potential remyelinators. Clemastine, miconazole, benztropine, and clobetasol. I'm going to talk a little bit about Clemastine because it has had probably is the furthest along. Clemastine is the active ingredient in Tavis-D, over-the-counter antihistamine. It's been around forever. Who would have thought that Clemastine would potentially repair myelin? So in the small study that was done at UC San Francisco, they took 50 individuals with MS who had optic neuritis, and they had permanent visual loss from their prior bouts of optic neuritis, treated them with daily doses of Clemastine for 6 months, had a placebo group also, and they looked at a couple different things. They looked at visual recovery with this, improvements in visual acuity, and they did something called visual evoked potentials. That's measuring how long it takes the electrical stimulus to get from point A, the retina, to point B, the occipital lobe, the visual cortex. That's a measure of how healthy your myelin is. And what they showed is that they got visual recovery and they got faster conduction time from point A to point B, so they were remyelinating. So there's a much larger trial starting up now. Fingers are crossed to see if this is going to work out. This sort of treatment they're anticipating that it wouldn't be a forever treatment, that it would be something you would do for about a 6-month block of time and hopefully see some improvement. When you start looking at trials into neural repair, what you're going to see in a lot of these trials is that they're going to look at 2 outcomes typically in multiple sclerosis. They're most commonly going to look at either visual function or walking. That's not to say that other things couldn't get better. Your cognition could get better. Your upper extremity function could get better. Visual acuity and walking are just easy to measure. They're reproducible, especially visual testing. So I wouldn't stress that that's the only things that a neural repair agent might improve. Those are just the easiest to study. So this is one that I think we've mentioned several times here, Anti-LINGO. Of course, we've got to give it a more difficult name because Anti-LINGO was too easy, so it's Opicinumab. And as you know, so MAB, monoclonal antibody, if it has the U in front of it, it means it's a humanized antibody. So this whole world of MAB drugs is just exploding. Monoclonal antibodies are used across a wide range of health conditions. Next year, we're slated to have the first round of monoclonal antibodies for migraine headache prevention. We've not had a new drug for migraine headaches in probably 15 years in terms of a new mechanism of action. So the story behind Anti-LINGO is that they identified a molecule called LINGO-1 that actually seems to inhibit OPCs. So you've got these oligodendrocyte progenitor cells that would love to grow up and make myelin as they become oligodendrocytes, and this LINGO-1 molecule is preventing them from doing that. So Anti-LINGO is a monoclonal antibody that inhibits the inhibitor of those OPCs. So what do we know in the trials to date? They've been hit or miss. So the RENEW trial was a study looking at optic nerve damage and visual recovery. And what they saw was that the visual acuity didn't improve, but the retinal nerve fiber layer, how healthy nerve fiber layer was, didn't improve either, but there was a hint, didn't reach statistical significance, there was a hint that the visual evoked potentials were speeding up in these individuals. The Synergy trial looked at just disability in general, was also negative. There has been a concern that maybe there were dosing issues with the Anti-LINGO, so now we do have a huge multinational 50-site trial called Affinity that's starting up next month, looking at improving disability overall. So we're one of those 50 sites. This is an IV drug given once a month for 6 months. It's a double-blind, placebo-controlled trial. We don't know which treatment people are on. The individual doesn't know which treatment they're on. At the end of their 6-month window, they will unblind those individuals. We'll know, they'll know. And if the study goes like most studies go that we've participated in, we would anticipate that if you were in that placebo group in the first round, typically the study sponsor gives the individual the opportunity then to move on to active treatment so that everybody is on treatment. This trial is weighted towards some research MRI metrics and disability. Of the disability part is probably looking most at walking. So I would say this is more of a walking trial than a visual acuity trial. The frustrating thing, like so many trials, is we have inclusion and exclusion criteria. They give us a pretty skinny box of who they're looking for. I want to say in this trial the upper age limit is 55, and the person has to be able to walk some. I think that what they're saying is you have to be able to at least walk with a cane in this trial. So it's going to weed out, unfortunately, some individuals who don't fit in that box. But if this study looks good, again, it's a fairly short trial, 6 months of active treatment for the individuals. Once these things are FDA approved, if it works, you know that then we can roll it out to people who don't fit in that initial box. So the last topic that we're going to touch on is these OPCs themselves. So we just talked about sort of trying to identify molecules that would actually stimulate OPCs and make them become oligodendrocytes and make myelin. What if we just gave you OPCs? What if we could just transplant these into your body and have you make myelin naturally? So oligodendrocyte progenitor cells are immature cells that can become myelin-producing oligodendrocytes. There's another type of cell that I'm going to mention called an induced pluripotent stem cell. I get tongue-tied with these too. It's another way of getting to the OPC. So with an PSC, what you're doing is you're taking a cell that is less mature and you're making it become hopefully that oligodendrocyte. So what are some of the challenges with OPCs? If we could harvest these from people, and then make myelin, why don't we just do that? Why don't we put them into the bloodstream? The problem is these cells, if you put them in the bloodstream or you put them in the spinal fluid, they don't go anywhere. They have to be put into the brain or spinal cord directly. They will migrate. If you had an area of damage in the brain in one site and you injected these OPCs, say 3 inches away from that, it does look like they go to where the damage is and will potentially remyelinate, but you still have to put them into the brain or spinal cord itself. A lot of disability that we see in multiple sclerosis comes from spinal cord lesions. Again, the appeal of putting a needle into the spinal cord is very, very low. You can take an individual who has one level of disability and actually worsen it because you've now injured the spinal cord by putting that needle into the cord. The other somewhat ethical concern is that the primary source of OPCs is fetal tissue, and you get into all of the ethics that go along with where those cells are coming from. The appeal of these induced pluripotent stem cells is that they come from the patient themselves, and they're present in lots of different tissue. So what you're doing is you're taking this cell, and in the test tube, you're making it think that it's a stem cell. And there are a lot of different ways that they've been able to do this. And so what you see is all the different tissues on the bottom of that graphic that those pluripotent stem cells can become. That's a blessing and a curse. That's kind of like a genie in the bottle. When that cell has the potential to become a lot of different things, and now we put it into your body, how do we know for sure that it's going to become the cell that we want it to become? Some of the trials with these sorts of cells have had some success. They've also sometimes, one of the studies that we did with a cell similar to this, these cells actually became tissue in the spinal cord that you didn't want them to become. They became something called atypical glandular tissue, which sort of looks like stomach lining. It's not cancer, but it's not normal, and it definitely shouldn't be in a person's spinal cord. So the trick with this line of research is how do we sort of harness the genie and send it to the direction that we want to go down and not becomes tissue that could be damaging to a person. So one of the things that we've not talked about tonight, a lot of the focus has been on repairing myelin. And if you've been to some of these lectures, if you've read up on MS, you know that MS is more than just a demyelinating disease. It's an axonal transecting disease. So the axon is the nerve fiber, the myelin is the insulation. We know that MS strips the insulation, but it can also cut the nerve fiber itself. A lot of the treatments that we've talked about here tonight, really, we don't know yet. Do they repair the nerve fiber itself, or do they just remyelinate? In a given individual with MS, the disability that we see is probably a combination of axonal transection and myelin damage. And with some of the newer MRI techniques that we're looking at, we might be able to sort that out. For instance, in this Anti-LINGO trial that's starting up, we're using an MRI technique to try to select the right individuals who probably have more myelin damage than axonal damage to give them a better chance of success. But that's not to say that we're not trying to look at that axonal damage as well. There is research looking at what inhibits axonal regeneration in the central nervous system. If you were to damage a peripheral nerve in your arm and you went to a neurosurgeon and they took that severed nerve and stuck it back together and sewed the lining of that nerve together, there's a good chance that some of those nerve fibers would hook back up again and regenerate. That doesn't happen in the brain and spinal cord, and one of the questions is why? What is it in the human brain and spinal cord that prevents this axonal regeneration? And researchers have identified at least two things that appear to inhibit axonal regeneration. Myelin-associated inhibitors, which you would think would inhibit myelin, but they're actually inhibiting axons as well, and then something called chondroitin sulfate proteoglycans. So there is a very active research program going on now trying to develop inhibitors of these inhibitors of axonal regeneration. So I appreciate you guys hanging in there. That's a lot of big words and concepts to throw out. But it's exciting to me where we're at in the whole search for neural repair. We've always said that in MS, everything we do right now fits into one of three buckets. We're treating relapses, we're managing symptoms, we're stopping progression of the disease. We know there will be a fourth bucket someday. That will be reversing disability and pushing the clock backwards. I think for right now, what we can say is that autologous hematopoietic stem cell transplantation looks like it may be a viable treatment option, probably best thought of for the younger under 50 MS patient with aggressive relapsing remitting disease. That's not to say other types of MS are not being looked at as well. Mesenchymal stem cell transplantation. The research appears very promising, and I think that is we know it's a safe way of addressing reversal of disability. We just need to get better at it, work on the dosing, work on the route of administration so that we can standardize that. These molecules that take advantage of natural repair mechanisms, again, the research that's being done now to letting us identify potential candidates very quickly through micropillar arrays, I think is moving the ball ahead very quickly. And we do have a large multinational trial with Anti-LINGO that is starting up literally as we speak. And fingers crossed this trial is going to have better results than the first two did, and that the third time will be the charm. Thank you guys very much for coming out. Thanks for holding the questions this evening. And with that, I will turn it over to you guys.